Welcome to this episode of the Neurology Video Journal Club, in which Maudy and I will discuss a very interesting paper entitled Long-Term Safety and Efficacy of Avalglucosidase Alfa in Patients with Late-Onset Pompe disease, which was published in the May issue of 2022. The first author was Mazen Dimashki from the University of the Kansas Medical Center. My name is Marianne de Visser. I'm an emeritus professor of neuromuscular diseases at the University of Amsterdam, the Netherlands. And Maudy, please, could you introduce yourself?
Yes, thank you for the introduction. My name is Maudy Theunissen, and I'm a PhD candidate at the Center for Lysosomal and Metabolic Diseases of the Erasmus University Medical Center in the Netherlands. And I focus on research into the mechanisms that underlie the differences in response to enzyme replacement therapy in adults with Pompe disease. And by combining clinical data and patient-reported outcomes, I hope to improve and personalize treatment for these patients.
Let's start with some background on Pompe disease. And perhaps you could walk us through the clinical picture and the course of the disease, Maudy.
Yes, of course. So Pompe disease is a rare metabolic myopathy due to disease-causing variants in the GEA gene. And these variants lead to a deficiency of the lysosomal enzyme acid alpha-glucosidase. And this results in glycogen accumulation in the lysosomes, particularly in muscle tissue. Ultimately, it will lead to cell destruction. The clinical spectrum of Pompe disease is broad and continuous. It mainly depends on the level of residual endogenous alpha-glucosidase and the GEA variant. The most severe phenotype, which is the very end of the spectrum, is classic infantile Pompe disease. And this usually presents within the first months of life and is characterized by hypertonia. This is depicted on the first picture of this slide. They also present with a delay in motor development and hypertrophic cardiomyopathy. If this phenotype is untreated, most infants die before the first year of age. You then also have the late onset form of Pompe disease, the non-classic form. These patients can have a disease onset at any age, ranging from early childhood to late adulthood. And they have a more slowly progressive disease course compared with the patients with the infantile phenotype. The patients with late onset Pompe disease have axial and limb girdle weakness, and also the diaphragm and other respiratory muscles are involved. So patients, for example, have difficulty with climbing stairs, second picture, or walking, third picture. And ultimately, these patients can also become wheelchair and or ventilator dependent, fourth picture. Since 2006, enzyme replacement therapy with recombinant human acid alpha-glucosidase, and the name for this enzyme replacement therapy is then L-glucosidase alfa, has been registered as a treatment for Pompe disease. In infantile Pompe disease, this therapy improves cardiac function and also establishes that patients reach new motor milestones. So part of the patients, for example, learns how to walk. And the therapy also drastically improves survival. In late onset Pompe disease, enzyme replacement therapy stabilizes or improves most patients' respiratory and or motor function. An example is then depicted on the left graph at the bottom. This graph concerns the forced vital capacity in upright position, and it shows that patients with Pompe disease deteriorate over time, and when they're treated with L-glucosidase alfa, the course changes compared to the expected natural course. In this graph, the dotted vertical line shows then the start of therapy, and from there you see how the course over time changes. However, many patients also experience a secondary decline in walking ability, muscle strength, pulmonary function after mostly 3 to 5 years of treatment. An example of this is given at the bottom. It's the right graph. It's an example of the secondary decline.
You mentioned this secondary decline, Maudy. Do we know how this happens?
It's not completely understood. There are hypotheses about factors that may influence reduced treatment efficacy. This could be, for example, the amount of autophagic buildup interfering with intracellular trafficking and processing of the administered enzyme. Could also be accessibility of the enzyme to accumulating glycogen within the cells. Of course, it could also be age-related decline in muscle. But another explanation for reduced efficacy might be that the enzyme does not reach the muscle properly. We do know that exogenously administered functional enzymes reach the lysosomes through mannose 6-phosphate receptors on the cell surface. So one might argue that the content of mannose 6-phosphate groups on the administered enzyme have an influence on the effectivity of the enzyme. And this is also where Avalglucosidase Alfa, the enzyme replacement therapy discussed in this paper, jumps in. Could you maybe please clarify the difference of Avalglucosidase Alfa as compared to L-glucosidase alpha?
Yes, Avalglucosidase alpha is what we call a next generation recombinant human acid alpha-glucosidase enzyme replacement therapy. It has a 15-fold increase in M6P, mannose 6-phosphate content compared to L-glucosidase alpha. And therefore, one might argue that Avalglucosidase alfa will improve M6P mediated uptake, glycogen clearance, and also clinical efficacy, even more so than L-glucosidase alfa.
I think this 15-fold increase that you're talking about is, could be really promising. I think it's also good to mention that Avalglucosidase alfa received marketing authorization in several countries already. First, it got approved in the US in August 2021 for patients with late-onset Pompe disease of 1 year of age or older. And these days, also the EMA has approved it. This specific paper provides then the data on long-term safety, efficacy, and pharmacokinetics of Avalglucosidase alfa in adults with late-onset Pompe disease, who first enrolled in the 6-month phase 1 NEO-1 study and then subsequently entered the NEO-X and NEO-1 extension study.
Yeah, a little bit more about the study. The primary objective of the study was to assess the long-term tolerability of alpha-glucosidase alfa in people with late-onset Pompe disease after up to 6.5 years. And let me share some data on the methods of the study. In the NEO-1 study, Avalglucosidase alfa was administered intravenously every other week to patients suffering from genetically proven late-onset Pompe disease who were over 18 years of age. And they had to be able to walk more than 50 meters without stopping or using an assistive device. And they had to have an upright forced vital capacity of at least 50% predicted. They could either be a treatment naive, and then they belong to the naive group, or previously treated with L-glucosidase alfa for more than 9 months, and then they were called the switch group. In both groups, there were 3 dosing regimens, 5, 10, or 20 milligram per kilogram body weight for 6 months. The NEO-X study is a long-term open-label extension of NEO-1, and the patients continued on their assigned NEO-1 dose for 2 to 3 years until receiving 20 milligram per kilogram body weight every other week. Data cutoff was pre-specified and was 6.5 years after first inclusion of NEO-1. The primary endpoint was, as we said, safety, but there are several secondary endpoints, including pharmacokinetics, pharmacodynamics, pharmacogenetics, and also exploratory efficacy measurements. There were actually 2. The first one was a 6-minute walk test to test walking and endurance. And this test quantifies the distance a patient can walk at his or her fastest pace possible within 6 minutes. And the other outcome measure is the pulmonary function, assessed by forced vital capacity, or MIP and MAP, maximal inspiratory or expiratory pressure. Do you think, Maudy, that these two outcome measures, the 6-minute walk test and the pulmonary functions, are good exploratory efficacy endpoints?
Yeah, I think for a trial, these are valid choices for efficacy assessments. Because after the first placebo-controlled trial that finished in 2007, these outcome measures are widely used in research regarding Pompe disease. And of course, you want to be able to compare your results to previous research. Also, the FDA considers these outcome measures clinically relevant. And of course, in trials, mostly patients are included with a certain level of walking ability or lung function to be able to measure improvement or decline, for example. The limitation then is with outcomes like this, how do you deal with this in your Pompe community when you also need to follow up on patients in a wheelchair, for example, or patients who can't perform a forced vital capacity?
Indeed, this is something we have to keep in mind if we want to translate the results to the whole Pompe community. Do you think that the methods show other shortcomings, Maudy?
Yeah, so in this paper, they have used incremental dosing, which I think is valid if you do a safety study. However, they only dosed up to 20 milligram per kilogram of body weight. This is also the standard dose for L-glucosidase alpha, so I think it makes sense to examine the same dosing. However, as a doctor, of course, I question if you should dose higher for better results. Also, I think you need to keep in mind when you're interpreting the results that they use these lower doses. If you don't see much improvement, for example, it could be because of this, that they use lower doses.
Yes, I agree. And also there was no comparator arm and the study was not blinded nor randomized. And they also did not use patient-reported outcomes, including measures of participation, of daily activities, and of quality of life. And of course, this study is set up as a safety study, but they also looked at efficacy measures. And I think patient-reported outcomes would really have been of value in this study. Shall we proceed with the results section? Perhaps you can start.
Yes, so in the beginning, 24 patients enrolled into NEO1. 21 patients have completed this study, and then 19 entered the extension study. 2 patients discontinued because of personal reasons, so 17 remained at data cutoff. And if we then look at the baseline characteristics to start with, the average age at study enrollment was similar in the naive and in the switch groups. It was 44.8 years for naive and 46.7 years for the switch patients, but the range of age was fairly wide, 19.8 to 78.3 years of age. And besides, also the average age of diagnosis of Pompe disease was a little higher in the naive group, 43.3 for the naive group and 36.3 for the switch group. So the switch patients have a little longer disease duration at study enrollment. I think that's something to keep in mind. What do you think about the patients included?
Well, there might indeed be some limitations here as well, and this is also discussed by the authors in the discussion section. The sample size is rather small with only 17 patients at cutoff, data cutoff, and there is a wide range of age at enrollment. But let's have a look at the results of the safety part of the study. All 24 patients had one or more treatment emergent adverse events. In total, there were 1,960 events reported, mostly mild and across all doses. And nearly 92% of the adverse events were considered unrelated to study drugs. So that's quite reassuring. Most frequently reported adverse events were fatigue, headache, nausea, and rash. There were only 2 patients with a serious adverse event, probably infusion related. There were no deaths and no life-threatening treatment-related serious adverse events occurred during this study. What do you make of these results?
Yeah, I think Avalglucosidase Alfa shows treatment-emergent adverse events similar to what we know from other enzyme replacement therapies. So I think overall this study shows that Avalglucosidase Alfa is safe to administer, and that this is also what the authors conclude. If we then proceed with the efficacy outcomes, results are presented on upright forced vital capacity and 6-minute walking test, and they are expressed as a percentage of the predicted normal value for that patient. So it takes into account the age, for example. And if we start with the results on forced vital capacity, trends are shown in these figures that we're showing now from the paper. Slope estimates for trends in upright forced vital capacity percent predicted were minus 0.47% per year for a naive patient and minus 0.65% per year for switch patients. So there was no big difference between the two groups observed. And this trend is depicted as the black lines. This is then less than the natural course of these type of patients, because that would be around minus 1% per year. And if we look at these graphs in a bit more detail, which patients stand out to you the most?
In a naive group, let's start with that one. The turquoise line seems to be an outlier, and this concerns a 83-year-old patient with worsening of an aneurysm of the aorta at week 156. The patient underwent surgery and then presented with infusion-associated reactions at week 169. And the complaints were fever and shivering during subsequent alpha-glucosidase alpha infusion. And at this point, the patient had a very high anti-drug antibody titer of more than 12,000 and a peak titer of more than 15,000. And she tested positive for enzyme uptake inhibitory antibodies. In week 208, so at 4 years, she was diagnosed on top of the late onset Pompe disease with chronic inflammatory demyelinating polyneuropathy. And this all could have influenced the course of Pompe disease and explains the slope of the curve. And could you comment on the patient depicted as the lime green line in the switch group?
Yes, I think the forced vital capacity seems to recover around week 156, and this might be due to change from the initial 5 milligram per kilogram dosing to 20 milligram per kilogram. And also, of course, this makes me wonder how the course would have been if patients would have been dosed even higher.
And maybe you can continue with discussing the change in motor function over time.
Yes, if we first look at the top two figures that are shown now, these are from the paper. Slope estimates for trends in 6-minute walking test percent predicted, so the black lines again, we're minus 0.7% per year for naive patients and minus 0.85% per year for switch patients.
There are also some outliers in this figure, Maudy, which you might want to comment upon.
Yes, in the naive group, again, I think the turquoise line stands out. This was the 83-year-old patient with an aortic aneurysm, infusion-associated reactions, and CADP that you just discussed. In the switch group, I think two patients stand out to me. I would say the yellow line. This was an 68-year-old patient with a medical history of left upper lobectomy for upper left lobe lung cancer and developed right upper lobe lung cancer, ribcage pain, and right renal cell carcinoma. And I think also the royal blue line stands out to me. And this was a 64-year-old patient with a history of gout, Bell palsy, episodes of acute diverticulosis, Clostridium difficile, and also chronic hip and back pain. And I think their concomitant diseases could have influenced the course of these outcome measures as well, besides Pompe disease. What is also interesting, I think, is that the authors state that the baseline functional status, so they looked at 6-minute walking test distance, not percent predicted, and forced vital capacity percent predicted in upright position, that this was better in participants under 45 years of age compared with those over 45 years of age, regardless if they were in the naive or in the switch group. They then suggest that the 6-minute walking test distance improved in most patients who were under 45 years of age at the start of NEO1 and have ever received 20 milligram per kilogram Avalglucosidase Alfa. This is shown in the bottom figure from the paper as well. These lines are individual patients who ever received 20 milligram per kilogram Avalglucosidase Alfa, and then the authors compare the 6-minute walking test distance by age at baseline, so at first visit, and at last assessment. However, I find it a bit difficult to interpret these results because here they used 6-minute walking test distance in meters instead of percent predicted, so they didn't take the age into account. I think it would be better to compare 6-minute walking test percent predicted to correct for the effect of age, because I don't expect a 70-year-old to walk as much within 6 minutes as a 20-year-old. But I would like to know if these 70-year-olds with Pompe disease walk as much as other 70-year-olds without Pompe disease. And of course, you also need to be careful interpreting results on the course of Pompe disease because of age-related physiologic muscle wasting, sarcopenia, or other comorbidities affecting mobility or exercise tolerance. Could you please continue with discussing some results on immunogenicity?
Yes, these data are interesting and actually also somewhat remarkable. 18 out of 24 patients developed anti-drug antibodies with a median peak titer of 1600. One patient developed a peak anti-drug antibody titer at 12,800. We already discussed that patient, and one patient at more than 50,000, and both showed decreasing anti-drug antibody titers over time. 5 naive and 2 switch patients tested positive for neutralizing antibodies at intermittent time points without an apparent effect on clinical outcomes. And what I find remarkable is that not all patients with neutralizing antibodies also had high anti-drug antibodies. In the 5 naive patients, the anti-drug antibodies ranged in one patient between 100 and more than 50,000, but in the other 4, between 100 and 3,000. And the 2 switch patients had even lower titer ranges, between 100 and 400. And this is interesting and somewhat remarkable, as I said, because neutralizing antibodies during treatment with Avalglucosidase Alfa are mostly seen in patients with high anti-drug antibodies. The authors did not investigate the neutralizing effects on the intracellular enzyme activity, and I think this is something to look further into in new studies. There were 6 patients who tested positive for enzyme uptake inhibitory antibodies, of whom 3 also tested positive for enzyme activity inhibition.
And were these the 2 patients with the high anti-drug antibodies? Were that the 2 patients that had serious adverse events related or possibly related to treatment?
Well, one patient with infusion-associated reactions at week 169, again, the patient we already discussed, the one who experienced fever and chills, did indeed have an anti-drug antibody titer of more than 12,000 at the time of the serious adverse event. But the other patient with a serious adverse event, manifesting with respiratory distress and chest discomfort, did not have a high anti-drug antibody titer. And
what about IgE antibodies?
Well, IgE was tested obviously only in patients who presented with infusion-associated reactions and hypersensitivity reactions, but none of them developed IgE antibodies. And Maudy, can you discuss the results of the biomarker part of the study?
Yes, of course. The authors have demonstrated that there is a tendency for improvement of elevated baseline HEX4 levels, so glucotetrasaccharides, I hope I say it correctly, which is a biomarker that demonstrates the burden of glycogen accumulation because excess glycogen is degraded to glucotetrasaccharides. The same tendency for improvement we see for the elevated baseline CK levels, which demonstrates the burden of muscle damage. And this both could indicate that there is stabilization of the pathologic process in muscles. And overall, we also see that the enzymes aspartate transaminase, AST, and alanine transaminase, ALT, decreased from baseline to last on-treatment measurement. Can you please proceed with what is reported on pharmacokinetics?
Yeah, sure. The alpha-glucosidase alpha exposures increased proportionally between 5 and 20 milligram per kilogram, and no accumulation was observed following every other week dosing. The pre-dose concentration at week 26 at re-baseline, that is assessment after switching and the first 20 milligram administration, and at week 208 was below the lower limit of quantification in 70% of the patients and slightly above in 30% of the patients. At these time points, so week 26, re-baseline, and week 208, the PK parameters appeared similar, indicating time-independent pharmacokinetics.
And were there then differences in pharmacokinetics in the naive and in the switch patients?
No, this was not the case. At 20 milligram per kilogram, patients in the switch group showed similar Avalglucosidase alpha pharmacokinetics as compared to those in the naive group, whatever the dose. So if we summarize this paper, the data suggests that treatment with alpha-glucosidase alpha is safe, and it also suggests that the drug has a positive effect on respiratory function, endurance, and walking ability. And the authors found that this study provides class 4 evidence of long-term tolerability and sustained efficacy of alpha-glucosidase in patients with late-onset Pompe disease after up to 6.5 years. I do think, based on these data, that Avalglucosidase alpha can be promising. However, as we discussed, the study has some limitations: small sample size, no comparator arm, the use of lower doses, which might have influenced the outcomes, and wide age range at baseline. And of note, alpha-glucosidase alpha has already been investigated in a randomized double-blind phase 3 trial called the COMET trial, and very recently the results of an extension up to 97 weeks have been published, which show a great similarity with the data from this paper. So what do you think about the clinical applicability of Avalglucosidase alpha, Maudy?
Yeah, I think Avalglucosidase alpha is potentially very promising. However, like you said, it needs to be further investigated with more long-term data and larger cohorts, because that's still a bit unclear. And also other enzyme replacement therapies are currently being developed. Also a phase 3 study has been done for this, and it's unclear yet how they relate to each other. There are also developments going on in for gene therapy for Pompe disease. So yeah, I'm very curious to see what will happen in the next couple of years in the field of Pompe disease, and how standard of care might change with multiple treatment options on the market. It is clear, though, that there is still unmet needs for improvement of the motor and respiratory functions for patients with Pompe disease.
Well, thank you, Maudy. I very much enjoyed discussing this interesting paper with you. And I really hope that our audience has gained some more insight into this study.
Thank you. I really enjoyed doing this.